everyone. It is time to do updates for PCS. It's that time of year again. Now, if you have joined us before, you know we've already done the 2020 ICD-10-CM updates. But now we're going to talk about ICD-10-PCS, which is the procedural inpatient codes. And it is much more intense, the updates, than you would get with CM, because PCS is a multi-axial code set. So if you delete something in PCS, not so much of a big deal, but if you add something to PCS, then in any of the characters, but it's usually the last three characters that something adds to, you're looking at 10, 20 possibilities or more that changes. So we're going to start out kind of slow and talk about the changes, and then we're going to ramp up and move faster as we get to going along, because a lot of this will be repetitive, and I'm not going to read these slides. I'm just going to make you aware of them so that when you see that a device has been added as an option now to one of our last two characters or a qualifier, you can go and research that yourself. I don't need to show you every single code that it affects. And we'll just use it as a launching point for you to go and do your own research. So it's still a lot of fun, but let's look at the statistics really quickly. So with 2019, we had 78,000 codes. And then we dropped down to a little more than 77 with 2020. They deleted some things, but actually they kind of fine-tuned so don't feel like we're losing codes. It's not really, it's options that, in my opinion, probably weren't as relevant as they thought that it would be, or they're not being used, and so they changed them or reworded them. New codes, we have only 734, right? We deleted over 2,000 codes. We have only 2 revised titles, and it's pretty, pretty unique. It's to clarify, and that's what you usually see. With ICD-10-CM and even with CPT, when you start seeing the updates and everything, a lot of this is clarifying. It's making the code set better and more applicable to what's being used. So here is a breakdown by section of the codes. How many code options? I like to call them code options because, yes, they are individual code sets, but with PCS, again, it's multi-axial, so it's not like you've got one code in CM or one code in CPT. It is an expandable and diverse code set, really brilliantly put together, quite honestly. And as most of us already know, Med-Surg is the largest area of PCS, but here's a breakdown of the codes that are in our other sections if you want to kind of give that the old hairy eyeball and look. Our coming in at number 2 is going to be imaging, and then radiation therapy, and then you've got rehab, diagnostic audiology, which is mostly it's rehab there, and then administration, things that we're administering to the body. But again, just an overview if you were curious about how many codes or coding options there were in each one of the sections. For the most part, there's some little changes in almost all of them, but not all of them. Moving right along, don't forget, just like the other code sets, we have new guidelines. So we'll go over those first, and then we'll start looking at some of the updates. So the first one, what they did was for radiation therapy, for brachytherapy, and and know that there are some changes in the codes. Whenever you see a guideline that has changed, then it's going to reflect probably in some changes in the codes, whether it be wording or options that are given to you. So our first one is going to be on brachytherapy, and notice that this is going to be divided up into two things. One, where you're leaving the little seeds in the body, okay, and the root operation is going to be insertion. Everything's about root operations, honestly, with PCS. And if you're new to PCS, again, it's a brilliant and quite easy to use code set once you understand it. It's very intimidating to look at because it's multi-axial. You know, every one of your characters can launch off. You know, I think of it as launching off into another tangent, another area. But if you think of multi-axial, when they say that, what they mean is think of a wagon wheel, you know, and so you're starting out like in med surge, and then each one of the spokes will send you off in another direction, right? But the root operations, once you comprehend the root operations, PCS is literally a piece of cake. So this first guideline will be reflecting on insertion, okay? But also with these procedures, notice that if you do a separate procedure to place a temporary applicator for delivering the brachytherapy, you're going to also use the root operation of insertion. But that device value will be added as well, okay? So if you're not dealing with brachytherapy, this guideline, you know, it just explains it, adds it, makes it a little more unique. I hope that you can see the highlight here of what is new. Okay, just like the other code sets, when they put something in bold, then you know that it's new content. So now we're going to be talking about the instruments. They are intended to provide direction that is applicable in most circumstances. However, there may be unique circumstances where exceptions are applied. So that's talking about the guidelines and that accompany and complement the official conventions. So again, they just added this to clarify. Okay, so notice here how they put it's a response to public comment and internal review, you know, and that's really what the updates are about every year for the most part. All right, now we're going to get into some of the more meaty stuff. We're going to talk about some of the conventions that changed. They added Y as an other device that was added to the table. For med surge subcutaneous tissue, if you're inserting something, now we have other device. Before we had radioactive element and we had infusion device, but what does that tell us? That obviously there's other devices being used. And then you see here is just an example of what we had previously on the device. That's all they did, was they changed that. Then for body system, they added this verbiage: anatomical region, general anatomical region, upper extremity and lower extremity. I always like to do a heads up when I'm explaining PCS. PCS, again, you can tell I'm a big fan because I keep talking about how brilliant it is, but it is worded just like your provider's document, how they're trained to document. They're unlike CPT, you know, and with PCS, it's all about the outcome of the patient, you know, the outcome of the procedure, whereas with CPT and procedures is what are we doing to the patient? Well, PCS is set up with the outcome, and that's the way providers think. You know, what's the outcome of the procedure? That, you know, why am I doing what I'm doing to this patient? So for body system, they just clarified and added the anatomical region. And I try to give people that are new to PCS a heads up, because if you can't find something when you're looking for the body parts and stuff, anatomical region, they've got general, lower, and upper extremities, it might be there, especially when you're talking about detachments, you know, which is only going to be upper and lower extremities. You're not going to be able to find that in the other sections, okay? But the heads up about this one, they've added that, and what we're talking about is that we're doing a procedure to an anatomical region rather than a specific body part. And they did a great example, so let's look at this. Chest tube drainage of pleural cavity. Now, this is going to fall under general for root operation. When we think of doing this procedures, we do think of anatomical regions. We think of upper and lower extremities for PCS, right? However, there is the anatomical region general that is classified here, and that would be the pleural cavity. So you're putting a chest tube in, which is a pretty common procedure, and we're going into the pleural cavity. The root operation is drainage. What's the outcome? We're draining something, fluid or ascites or blood, whatever we're draining from the pleural cavity. And the anatomical region is going to be classified as general, right? So if you're repairing the abdominal wall, right, that's going to be, if we're doing sutures and everything, that's still repairing, okay? But the anatomical region will be general, right? Root operations, they made some changes to that. So what they're saying in the guidelines is that a multi-root operation with distinct objectives are performed on the same body part, okay? Whenever you have an op and you're going to be doing more than one procedure, right, that we just use a different code, right? That's pretty self-explanatory. However, what happens if we have more than one root operation? We have more than one outcome that we're wanting to achieve, and we're working on the same body part. With PCS, that can be, you know, then it's not like CPT where we say, well, this one will get listed first because it's a more complicated procedure, things like that. No, PCS doesn't work like that. We're going to, you know, it's all about the outcome. And so they're telling you, they've put on here, distinct objectives, same body part. Example, we're going to do a destruction root operation of a sigmoid lesion and a bypass of the sigmoid colon. You can code them separately, okay? Two separate procedures on the same body part. They have distinctly different outcomes, two different root operations. That is possible to do with PCS. Again, it is truly brilliant to use this one. They also added the word extraction on this guideline for root operations. For excision extraction, repair, or inspection, whenever you have overlapping layers, and then it goes on to say the musculoskeletal system, et cetera, et cetera. What they're using as an example was really good. Excisional debridement that includes skin and subcutaneous tissue and muscle is coded to the muscle body part. Now, this is not difficult for us to understand because usually we go to the deepest, right, layer, and that's what you code for. And they did that with excision and repair, but now they added extraction to that. You have clarification. They clarified when we deal with a body part, if you see the prefix peri, okay, we all know that just means around, combined with a body part to identify the site of the procedure, then they're telling us that it's coded to the body part named. And this is going to allow more specificity if we don't have something specific in the PCS to deal with. Here's the example. I thought this was a really, really good one. A procedure site documented is involving the periosteum is coded to the corresponding bone body part. Okay. because it's the nearest body part. Simple. And that's the way we think, and that is the way our providers document. New technology. Now, just a heads up on that. Every year, you're going to get significant changes in new technology. Why? Because it's new technology. And it isn't like PCS or CPT where you get little baby codes and then they become codes. No, no. This is new technology where, you know, it's not going to be used that often yet, right? It's just getting started. So when you look at new technology, that's an X, and it allows you to use that code to explain what's happening. You very seldom have to use more than one code to do it. Now, with new technology, kind of draw yourself back and think for a second. This is stuff that not the billers haven't caught up with, the payers haven't caught up with, the providers are still figuring out how they're going to document what their protocol and stuff is. And so even though PCS is very black and white, whenever you have new technology, we're doing something with new technology, that's when you're going to pull back and say, okay, we code for statistical purposes, so we want to make sure that we're doing it as close and as to the highest specificity as we possibly can, right? So they state here that when you see section X, which contains a code title, and it fully describes the new technology procedure, and it's the only procedure that's being done, only the section X code is reported. You don't have to do more. There's no need to do codes from another area, okay, because it's new technology and it's the only procedure being performed. I kind of like that it's saying, hey, trust these new codes, trust the new technology. The example they use is the code XWO4321, introduction of, and I may not pronounce this correctly, so please be patient. Let's see, ceftazidime. Now you can have your little chuckle. Avibactam, anti-infective into a central vein percutaneous approach, new technology, group 1. And it can indicate that this particular anti-infective was administered via a central vein. And then there's a separate code from tables E3E0, which is an administrative section. And you don't have to code it because XW0 tells us we're administering this drug. We're administering it. We don't have to turn around and code for an administration as well. It's all in there. It's all complete. And I went and looked up some of this new stuff, this new technology, to see what it was. It was very interesting. And I'm going to share some of that with you, some of the things that I learned, because there's no sense in doing these new codes if you don't know what it's for, right? Now, new technology also, sometimes you have multiple procedures. So what do we do there? If you do have the X codes and they're coded following the multiple procedure guidelines. So what do we do when we do multiple procedures? Well, with PCS, it's pretty self-explanatory, easy to follow. And here's an example of multi procedures being done. So we're going to do a dual filter cerebral embolic filtration. Excuse me while I obviously got a fuzzy on my mouth. There we go. During a transcatheter aortic valve replacement. So we're doing a TAVR. I call it a TAVR. I don't know what other people call it, but we never say the long form of anything, do we? And we're going to do a cerebral embolic filtration dual filter in an innominate artery and left common carotid artery percutaneous approach. New technology. Now, this is actually something that's being done. They're doing this now. New technology group 2. So how do we code that? We're going to code for the cerebral embolic filtration, and we're also going to code for the TAVR procedure. Let's see, if you do magnetically controlled growth rod, the MCGR, placed in a spinal fusion procedure, okay, then you're going to look at the XNS for reposition of bones, and that is the code for the MCGR, and you're going to code with the spinal fusion procedure. So 2 really, really good examples. If you're not familiar with those procedures, hey, go look them up because they're very, very fascinating what they do. Med-surg, okay, now we've got some definition changes. We're moving into the next phase of what we're going over. The definition changes we'll spend a little more time on, and then we'll start speeding up because quite honestly, we have over 100 slides to get through. And I don't want you to lose traction or get bored along the way. So what did they do? They deleted in the term med-surg for operation for control. The explanation, the site of the bleeding is coded as an anatomical region and not as a specific body part. So 4.3, operation, stopping or attempting to stop post-procedural or other acute bleeding. There has been a change. Now, med-surg for body part as the character, been some changes. So we have the popliteal arteries, and they added to that the tibioperoneal trunk. Okay, so we didn't have that option before. And they also added for skin and chest breast procedures, skin only. Now, with new coders, a lot of times when they look for procedures on the breast, for some reason, they start thinking that it's genitourinary, but the breast is classified under skin and not genitourinary. They think of it being as part of the female reproductive system, and it's not. It's considered skin. So breast and procedures only, skin only, excuse me, has been added. And with the subcutaneous tissue and fascia and face, they added submandibular space. So we have more body parts, the 4th character in med-surg, okay? These 3 have been added. Tibioperoneal trunk, breast procedures skin only, and submandibular space. Moving on to the vice, the 6th character for med-surg, we added the precise intramandibulary limb lengthening system. Okay, so they've done that twice because we're doing lower bones and upper bones. And this is where you get into that repetition whenever you have laterality with ICD-10, right? And you make a change, it's automatically like 5 or 6 codes that are going to change. Then they deleted for intraluminal device pipeline embolization device, PED, okay, but they added, what they did was they broke it up actually. So we have an intraluminal device if it's going to be a flow diverter or for restriction in upper arteries. We now have 3 choices. We have a flow diverter embolization device, we have the pipeline and the flex, and we have the Surpass streamline flow diverter. Just giving us higher specificity, because before we only had the 1, and now we've got 3 options for a higher specificity. Monitoring devices, they deleted the reveal, the diagnosis in XT, but they added LINQ, DX, and XT. So again, for them to add the LINQ, we had to delete the previous option. Radioactive elements, they have added the SIVA sheet. And for subcutaneous defibrillator, when you're doing a lead in subcutaneous tissue and fascia, they have added the ICD lead. Higher specificity, pretty easy. And you know what? You may not even realize that these things have been added, because unlike other code sets where you kind of have things memorized, with PCS you don't. So you just go down. I like to call them a drop down. So when we go and look at that intraluminal device and we divide it up, that we're okay, we're doing upper arteries. You know, before we may have only had the embolization, the PED, but now we have 3. You won't even probably notice that you have a higher specificity there. So that's pretty good. Moving on, now we're going to go out of med-surg and we're in administration. Okay, this was like the next largest area of our PCS. With that, for the anti-effective envelope, we now have the antibacteria envelope and the TYRX antibacteria envelope have been added. Yay! So we have a higher specificity, pretty simple. That's the only change in administration. New technology, 3, operation. What they did was they took dilation as our root operation, and the definition, expanding an orifice or lumen of a tabular body part. They have a more information about the explanation. So now we know if you have an orifice, and it can be a natural orifice or an artificial created orifice, and it's accomplished by stretching a tubular body part using an intraluminal pressure, or by cutting part of the orifice or wall or tubular body part, because there was confusion there, right? No, we're stretching it, but oh no, you cut it. Well, that's how they stretch it. Measurement, the definition has been added, determining the level of a physiological or physical function at a point in time. Now, I want you to know, like I said before, the root operations, truly, once you know those and their definitions, PCS is really easy. So dilation, it makes perfect sense, right? Measurement, okay, we're going to just check the level of a physiological or physical function at a point in time. Now, with new technology, we had a lot of additions. I'm not going to read these. I'm just going to make you aware of them. So if you deal with devices in these new technologies, the substance in the technology for character 6, it is not unusual for the device, which the placeholder for character 6 and 7 are a Z when it's not applicable. They have added content that is applicable now. Now, let's just pull one in here and talk about it, because there's no sense in reading all of these. If you actually deal with this, then again, it's not a problem. So coagulation factor XA inactivated. We now have 1, 2, 3, 4 options for the definition. Okay, and if this is an area that you code, this all makes sense to you. Okay, we look at this interluminal device, sustained release drug eluting 4 or more in new technology. Look, they have a I'm going to say that's a Sabal below the knee, a drug eluting stent system. So they've got a below the knee stent system that was added. They were doing it, and now we have a code for it. With devices, they've continued to add more information, getting to a higher specificity. This is going to be an area that is always increased every year. So for internal fixation device, now we have an medullary limb lengthening. They can do upper and lower bones, which we knew that, and and we are doing an internal fixation device, as well as restriction of upper arteries intraluminal device with a flow diverter, which, remember, refer back to the previous editions and stuff with the flow diverter, intraluminal device aggregation table. So again, a lot of times it wasn't applicable, so it was a Z. We didn't have a information to put in there, so it was a placeholder. This was really interesting, and I did do some extra. We've already talked about the factor XA, some research on here, and added it in black for you. So XW03372, introduction of an adexient alpha factor XA inhibitor reversal agent into peripheral vein. That was all deleted. Percutaneous approach, new technology, et cetera, et cetera. What they did was they revised that to make it a broader statement. Inactivated coagulation factor XA into peripheral vein. Why do you think they did that? Because there's going to be more types of inactivated coagulation substances that they can use, in my opinion. And so they've opened it to be broad instead of saying that it's a specific type of agent. Now, if you don't know what this is, it's actually it's actually a chemical that is placed into the vein when you want to reverse the anticoagulation. So we have a person that's probably on Coumadin or other type of anticoagulation medicine. They are, or they're just bleeding, right? And so they're going to insert this medication chemical to coagulate the blood a little bit. I thought that was, and you can think of a lot of reasons why that would be done. In fact, it would be great if this is something that you see or you work with in your coding. Give some examples of procedures for us, put it in the chat and share so we can all do a little more educating of ourselves, increase our knowledge base, and look at that. So, because I had looked at that, and it's like, I mean, I know an inhibitor that it's probably going to stop something, but I didn't realize that it, and when the verbiage changes, you know, inactivated coagulation factor. Okay, so again, anticoagulation for uncontrolled. It made sense, but I wasn't very familiar with it. So I read an excellent article. Same thing with this other code. They just took out the specificity and kind of broadened it to say inactivated coagulation factor XA into the central vein. Now we're moving on to some fun stuff. This is where I like them adding to the tables because it teaches me something. That's the only way I can explain it. I like learning. So we're in med-surg. We're in the body part of cerebral, ventricle, and a qualifier, 7th character. They added subgleally space. And again, I know you're sitting back there and going, haha, I love the way she pronounces stuff. So have a good laugh while you're sipping your drink and enjoy the way I pronounce stuff. So I'm not going to go over the examples, but I'm going to tell you a little bit of why they added this. If you don't know what this space is, the subgleal space, first of all, you can break down the word. Sub means under. Anytime you have a word that's got like a GA in it, then it's probably got something to do with ganglia, right? And so I think of brain or nerves. And sure enough, it's in the brain. And so this space is between the skull and the membrane that covers the skull. Two common times that this space gets a hematoma. One's neonatal, so the baby's born and you get a hematoma that builds up. It can due to like a trauma of birth, it may not be an issue. You know, you got this bruising and stuff, but it can become a very dangerous issue quickly. So they've added this subgaleal space. And if you look here, we've got bypass cerebral ventricle to subgaleal space with autologous tissue, substitute open approach. And of course, you got the same thing, endoscopic percutaneous approach, percutaneous, and so on and so forth. So that's an example of how this addition, qualifier seventh character, will change. Same thing with this one. We've got med surge. We're going to be in the thoracic artery descending. And what are we doing? We're going to be working with the innominate artery, and that has been defined. So before we didn't have definition of that particular artery, now we do. And of course, you're going to see all of these additions, because what are we using? What type of tissue are we doing? Zooplastic, autologous, et cetera, open approach, you know, et cetera, et cetera. So again, higher specificity we're given. That particular artery is added to several different options or tables. So I'm just going to kind of slide through these, make you aware of them, because you can go back. If you're in our CCO club, you can go back and reference, and you'll get a copy. You'll be able to download a copy of these slides, whereas, or be able to view them. But if you're visiting us via a live stream, then this is the only time you're going to see it, right? This is a benefit that we give to our club members. So moving on, now this particular table in med surge, we have 24 new options. Again, multi-axial. So whenever you use one character, it opens up a field for options. If it's not applicable, it won't be given to you on this table. So let's just go off the top one. So we're in med surge, and we're going to be dealing with, now we have the option of the coronary artery, one artery, coronary artery, two arteries, coronary artery, 3 and 4 or more. We have the approaches have been added. Now we can go open, percutaneous, and percutaneous endoscopic. If you're newer and you don't know the difference between percutaneous and percutaneous endoscopic, it just means the endoscopic means you're visualizing as you're going. And then on top of that, we now have intraluminal device or other device. Remember, Y was added, and no qualifier, which is Z. You know, so what's an example? If we're going to do an insertion of an intraluminal device into a coronary artery, one artery, open approach. But now we have the option of doing 2, 3, 4 or more arteries. And it's, chances are, I mean, we know they're doing these procedures. We're going into more than one artery. And so not only did they add these arteries, then they have to add the approach and the device, etc., to expand and give us our multi-axial options. Very exciting. This is, I think, if you're in interventional radiology or, you know, cardiology, this is a game changer for you, and you are going to be happy to see this broadened. So they did the same thing here, more examples, and look, 48 were added because of this. Again, coronary artery, we've got 1, 2, 3, 4 or more. Okay, so we're going to supplement a coronary artery. Then we have the option of supplementing more. And then why is there so many? Because we have autologous, zooplastic, non-autologous to build on, right? So we have to have all of these options for one artery, all these options for 2 arteries, et cetera, et cetera. It's very exciting. I love this stuff. Then with 5 new codes in our, we had, okay, we're in med surge, and we are doing the innominate artery, And now we have lower extremity vein open to us. Ha, open. So we weren't able to use that before. So we're going to bypass that artery to a lower extremity with an autologous venous tissue open approach, et cetera, synthetic substitute. Higher specificity, same thing, lower extremity was added for subclavian artery, right and left. And then axillary artery, right and left, was added, lower extremity vein. And we're doing that, right? I mean, they're taking that lower extremity vein, and we know it's probably the saphenous vein, most likely. They're taking that and they're using it to do bypass in these other areas. And so now we can explain that to higher specificity. I'm not going to go through all of these because it's just going to list the brachial artery, right? You know, brachial artery left. Now we have that lower extremity vein that can be moved. Next, more new codes. We have more of the vascular system opened up. We can take a bypass for the ulnar artery to a lower arm vein. So we had to add ulnar artery right, radial artery right. We added the approach percutaneous. There's no device, but our qualifier is lower arm vein. Right, so all of that was added, 2 codes. That's the 2 that were added. But then we have to do the left, right? We have laterality, so it makes sense. Now we're going to get into 27 new codes, because if we want to do a restriction of an intracranial artery with intraluminal device with a flow diverter, they added intraluminal device flow diverter. We now have that as a device added. Before we had nothing, so it would have been a Z because we didn't have a definition, and now we have that. So 27 codes that could be built now off of that. Moving on, 6 codes have been added because they, in med-surg, they added gastric vein. So occlusion of gastric vein with extraluminal device. And before we could do the esophageal vein, but we couldn't do the gastric vein. They were doing it, and now we have a code for it. Oh, wow. 165 codes. What are we doing? We are going to supplement something. So in med-surg, O9U, and by the way, that's our first 3 characters. If you didn't know, I should have explained that. If you go look at O9U, now you have all of these added. You have the mastoid sinus with laterality, accessory sinus, maxillary sinus, frontal sinus, ethmoid, and sphenoid sinuses with laterality added. And you can see how that compounds the codes and gives us 165. So if we need to supplement the right mastoid sinus with an autologous tissue substitute, we've got a, and before all we had was a nasal terminate. Excellent stuff, isn't it? Oh, looky here. This just gets me so excited. I know. Yeah. And, I have to be honest, I'm trying to rein in my excitement to be as professional as possible for you. But when I see how expanded and to a higher specificity that we're getting with PCS, in my opinion, PCS is going to replace CPT eventually. It's just a better code set all the way around. It's so much more expandable. And so if this is new to you, I encourage you to take some time to look into PCS. You may not want to invest in a PCS manual if you're not doing inpatient procedures coding. because you're looking at over $100 investment. However, if you're using an encoder, get in there and pay a little bit of attention. Practice with PCS, see how wonderful it is, and reach out to some of your inpatient coder friends, network, come to us if you want to, and get a little practice with PCS. It's really a brilliant code set. Okay, so now I'll backtrack. I'll try not to reiterate my enthusiasm. Let's talk about the 108 codes that are going to be added for the small intestine. So if you are going to use your first three characters, ODI, or one, excuse me, this is going to allow us an example of bypass small intestine to cutaneous with autologous tissue substitute open approach. They added, first of all, they added the small intestine. We didn't have that option before to bypass. Now, not only did they open for the small intestine, we have open percutaneous endoscopic via natural artificial opening endoscopic approach. And that means they had to add all of these devices, which autologous tissue substitute, synthetic substitute, non-autologous tissue substitute, and Z is no device if we don't have one. And then on top of that, what are we doing? We got a qualifier. Is it going to be cutaneous, small intestine, cecum, ascending, colon transverse, colon descending, colon, and that should be an N moved over for sigmoid colon. Sorry about that. Rectum or anus. So again, see how it's you got 108 really quick, just because they added a new body part that you can code for. Very exciting. Same thing with the large intestine. And I'm not going to repeat all of this, but of course, if we did the small intestine, we need to add the large intestine, right? Same thing. And now we're going to move on to MedSurg ODX, an example of two new codes that we're giving. So in 2019, we could do the stomach, small intestine, and large intestine, right? Transfer large intestine to vagina. And if you don't know why they would do this, or usually there is a fistula that's caused for various reasons, where the large intestine has opened up into the vaginal vault, and you get drainage. You can have a fistula with the bladder as well, and they'll go in and they'll repair this. But anyway, this was different. I did find some research on this, but they're actually transferring it to, not repairing it. They're transferring it. And I thought, why would you do that? So there's got to be a reason. I wasn't able to find some, temporary, or why they would do that full time. I don't know, but I'm sure there's a reason. If you know why they would transfer the large intestine into the vaginal vault, let me know. Send a chat message, or because I know they repair that as a complication of something or a problem. But okay, so in 2019 we had this where we had the stomach, the small intestines, and the large intestines. But what they did was now they divided it up. Okay, see the difference here, that we now have this esophagus qualifier and esophagus vagina, whereas we didn't have that before. So again, I would love to know more about why they would do that, and I'm sure that you, somebody out there knows, can educate me. I always like learning something new. Moving on, now we're in OHD, MedSurg. We're going to be extracting something, and they added the ability to extract from the right breast laterality or bilateral, or supranumerary breast. And of course, since they gave us those, we only have one approach that can be used: open, no device, no to qualifier. And again, with CPT or with ICD-CM, an X is our placement holder, right? With PCS, placement holder, or it's not applicable, is a Z. So if this is new to you, make a note of that. So we can extraction of right breast. Now, if you don't know the root operation of extraction, then go take some time. It's all you have. You can Google it and get that definition. Some of these are getting a little harder to see. We'll navigate these. We wanted to be able to get them on the slide. And again, a special thank you, shout out to our intern who worked on this for us. She did a brilliant job. Very, very happy with how this turned out. But you have to take some of these tables and make them a little hard to see. And again, this is just a reference for you. This is a launching point for you to be aware of what you need to go pay more attention to. So now we have added cell suspension technique to replacement of scalp. Here's an example: replacement of scalp, skin, and autologous tissue substitute, cell suspension technique, external approach. So qualifier 2 was added, and that gave us 23 new codes. 2 new codes were given to us in MedSurg JH, so we can now define a device of subcutaneous defibrillator lead. So they had it before. It was probably a Z because the device wasn't listed, and so now we have subcutaneous defibrillator lead. So if we're going to do add a lead, open or percutaneous approach for your options. Oh, I think I clicked that, did it not? Oh, let's see. Oh, same thing. Okay, that's why it looked the same. It was almost the same. So this is OJW. The previous one was OJP, different body parts and everything. So we can remove this subcutaneous defibrillator lead. We can do a revision. These are all root operations that you need to be aware of. And the only thing that changed was the addition of this device. They gave us the revision, and there is, let's see, subcutaneous tissue, fascia, or trunk is our body part on that one. 6 new codes were given to us with OPH. So we're dealing with the humeral shaft, laterality here. Now the device we can add that is an internal fixation device, intramedullary limb. So we can insert this lengthening rod is ultimately what that is. And we got 6 new codes for that because probably we have open percutaneous endoscopic approaches available to us. Yep, there it is. Insertion and right femoral and tibia options. Then we have 6 new codes because they added to OWC. We're going to do an extirpation of matter. Now, extirpation is probably a root operation that you're not very familiar with. I urge you to go look it up, look at the definition. If you have a PCS manual, it's all through the manual, but you can Google it or you can go to your encoder. I am going to rein myself in and control myself and not sit here and explain all these root operations, because we have a whole lecture on that I absolutely love to do. It's already been done. You can go and find it in our club. But we are adding upper and lower jaw. Then, of course, if we're going to go and do an extirpation, we can do it open percutaneous or percutaneous endoscopic. No device, no qualifier. All of that has to be added. If we add a body part, anytime that 4th character is added, then we're going to have definitely approach, device, and qualifier additions as well. So now we know we can do that. Now we're going to get into our veins again. 302 administration. We're going to do a transfusion of an allogenic related T cell depleted hematopoietic stem cell into peripheral vein open approach. What did I just say? We added body system or region, 4th character. We added peripheral vein and central vein. So approach, substance, and qualifier have to be added. Unlike the previous one, we actually have it's administration. So they want to know, almost all your administrations say what we're administrating, the substance. And so with this, we've got U stem cells, T cells, and then of course qualifier, because we want to know, was it allergenic, related, unrelated, or unspecified? 12 new options there. I don't necessarily like calling them codes. I like calling them options. I mean, it is a code, but really it's options for a higher specificity. I look at things differently anyway, though, but whatever it takes for you to understand, right? For it to stick in your little gray matter, it's all that matters. We got only one new code here. Wow, only one. We're going to administer something. What are we administering? Introduction of hyperthermic, adenoplastic into peritoneal cavity percutaneous approach. Hyperthermic. It's just the qualifier that was added. All right, now this threw me, and this is another one I did a little research for you because, well, really for me, because I wasn't sure what this was. I was thinking, why are we inserting a hyperthermic? Now I know why you would insert a hyperthermic into the blood system, you know, like when you're doing procedures where you're cooling down the body when you do heart procedures and stuff. You know, I knew that, but it's like, why are we putting a hyperthermic into the peritoneal cavity? That I was like, I'm not sure why you would do that. Well, they do it for cancer. So introduction of this adenoplastic, meaning we've got a substance, we've got cells in there we want to stall, kill, slow down, something. And so I went and did some research. If you guys aren't familiar with NCBI, and they're all the time reading papers, back in 2013, which is also key. I made sure I added the 2013. So they were talking and researching and writing papers in 2013, how this was a treatment that's shown to be effective. And now for 2020, we're finally getting a code for it, saying that, yeah, they're doing this, and now we need a code. So they're introducing a hyperthermic adenoplastic into the peritoneal cavity, percutaneous approach, and they inject this anti-cancer agent to treat peritoneal
Stand by, everybody. We just lost Alicia here for a little bit.
What?
Yep, we just lost you for about 30 seconds.
Okay, well, I'll back up.
Okay.
So
wave your hand so I can edit it later. Thank you.
So I try to learn something new every year. And cardiology is one of the areas that I'm currently increasing my knowledge base on. And last year was interventional radiology. And so this is fascinating to me. So what this study was telling us is that back in 2013, they said, okay, they would just inject this treatment, this hyperthermic, into the vascular system, you know, and it would go around and kill whatever it wanted. But they're saying, hey, there are advantages if we go ahead and just inject this into the peritoneal cavity itself. It'll go in and slow down these cancer cells. So back in 2013, a paper was written about the advantages of it, and now 2020, we're getting it added as a qualifier to our code set. So really exciting stuff, you know, and that's where it goes into, we code for statistical purposes. It just happens to be a convenient way to get paid, you know. What we code from what our providers are documenting and the treatments and stuff, the protocols that are set in place, our coding that for them allows new protocols and changes in medicine. And you see this a lot with oncology. So I was very excited about that particular one. Now we're moving out to 2 new codes for administration. 3E1, we're working on the joints, and they added percutaneous endoscopic. So before we just did percutaneous, but now we can go in, add, and visualize at the same time. What is the 2 codes? They're going to irrigate the joints using an irrigating substance, percutaneous approach, percutaneous endoscopic approach for diagnostic, or not for diagnostic. So again, qualifier is, almost think of a qualifier as a modifier. You know, why are we doing this procedure again? What is there any extra information we need to know? Oh, this is diagnostic, or no, this is, we're just going in and doing it. Okay, now we have 4 new codes for monitoring the lymphatic flow. And I went and looked this up too, because I wasn't, I knew, I've seen this documented, but I didn't know exactly what it was for this. Let's see if I can say this well. Indocyanine green dye, which to me looked like cyanide, and I'm thinking, wait, what is that again? So this is actually a dye that's used to determine the cardiac output. Okay, and they don't write all that, so they call it like a green pack or whatever. Now, you know, we in the medical field we abbreviate anything, but they added that as a qualifier. That it is this chemical, this green dye, that's used to look at cardiac output, but not just cardiac output. It works with liver function, blood flow to the liver, and they also do parts of the eye, which I was not aware of at all. So parts of the eye to become more visible during medical procedures such as an angiograph. So not parts of the eye itself. I don't think they actually put it in the eye. I think they make it easier to the eye to see. Yeah, that's what it was. I misread that. Anyway, I thought that was cool. They added intraoperative if we're now going to do an extracorporeal oxygenation. It was continuous, but now they've done intraoperative. And if they added intraoperative, the qualifier is, how are we going to do this? Membrane, central, peripheral, let's see, membrane, peripheral, venal arterial, membrane, peripheral, veno-venous. So again, we were giving oxygen and intraoperative, and we can classify that. Why are we doing that? We need that for statistical purposes, honestly. 2 new codes for fluorescein guided procedures, and they added a method, fluorescence guided procedure, and then that meant that they had to add what they were putting in there, which is aminovolinic acid. And this is really, really cool. If you like to watch Dr. Sandra Lee and some of the procedures, she's works with keratosis a little bit. So it's this warty overgrowth of skin, you know, and they can be on the face and the scalp, and they actually use this as light treatment. So it's pretty cool. Let's see, 4 new codes for doing more of this fluorescence guided procedures. So now that they're just adding the method, simple. Getting through pretty quickly on these. Same thing, different part of the body. Again, these are just adding method. So I'm going to scan through these pretty quickly. But now we've got 4 new codes for low dose rate, LDR, brachytherapy. Remember, we had some guidelines that changed with brachytherapy, and I told you that we were going to be using those in here. And now they're showing up. Before we had Z as a qualifier, none. Now we have what we call unidirectional source. I know that's how you pronounce it because I took time to ask my children. I said, do you know what this word, how you pronounce this word and what this means? And both of my very smart children that I asked said, unidirectional. And I said, how do you know it's not pronounced unidirectional? And they both said, well, that wouldn't be right. Said, okay, well, how did you know that? And I said, well, what does it mean? And they said, you go in one direction. And I said, then why didn't it just say directional? You know, wouldn't that be a good diff? Anyway, that's how we homeschool off and on. So I'm always making my children do this stuff. It was so interesting that I thought, you know what? I think that's funny. Unidirectional, that I wanted to put the definition down there for you. And so I did put the phonetic spelling: moving or operating in a single direction, an unidirectional wind. But that is as far as when we're putting in these brachytherapy seeds, we're going in one direction, right? And if you aren't familiar with these seeds and what they're used for and stuff, it's really quite fascinating. But that is your word of the day: unidirectional, going in one direction. And it's pronounced uni. Unidirectional source was also added, gave us 9 options with more brachytherapy to bone marrow. I'm going to move through these pretty quickly. Low dose, again, unidirectional for brachytherapy of the eye. The ear and nose, same thing. Trachea, bronchus. They use this brachytherapy for all kinds of things. Esophagus, stomach. Liver, gallbladder. Pituitary gland, pineal gland. Left breast, right breast. Kidney, ureter. Ovaries, cervix, uterus. Prostate, testes. And that is, and also cranial cavity. And let's see, what's the difference in these two? Oh, unidirectional or none. Oh, head and neck. We're still adding. See, even though we have over 100 slides, some of these, there's no reason not to just skip through them pretty quickly. I told you in the beginning that we'll go slow and then we'll add, speed up a little bit. So we're still unidirectional. All of this brachytherapy: head, neck, chest. Look at all of these. Oh, no, this is new. This is new. Sorry. This isn't unidirectional anymore. Now we've got 48 new codes for dilation of right femoral artery with sustained release drug-eluting intraluminal device percutaneous approach, new technology, group 5. What does this mean? They're putting in a stent and they're dilating and putting in a stent. But all of this has been added. So X27 is new, and because of that, we have a list of all of these body parts that we can do this to. Our approach is percutaneous, but what are we going to put in? We could do all of these. We can do an intraluminal device sustained release. 2. We could do 2 of them. We could do 3, 4, or more, and this is all new technology, group 5. Exciting. Only one new code that is going to body part. Remember, body part means the other 3 are all going to have new content as well. So for a cerebral embolic filtration, single deflection filter in aortic arch, percutaneous approach, new technology, group 5. So we are now adding here, we're going to be able to put something into the aortic arch. Now, I happen to have not seen this procedure. Well, actually I did. I didn't physically go see. I watched a video on it and looked at this device. This is fascinating. This is really, really neat stuff. So please take some time to go look at some of these things they can do in the aortic arch. And they put this little filter in that stops clots. It's really cool. Next, we have new technology again. We're going to monitor the kidney using fluorescent. Let's see, pyrazine, external approach, new technology 5. So we're going to be working on the kidney and monitoring it. We had a lot of stuff added for that fluorescein already, and they added it into the new technologies as well. Another new one, introduction of, I don't know if I can say this, capillacism into subcutaneous tissue percutaneous approach, new technology. I'm not sure what that is. I should have looked that up. I think I went too fast. That will be a word. I'm going to look that up this afternoon. If you guys know what it is, tell us in the chat. Oh, look, we got 6 new codes. Why? Because we're going to do something new to the peripheral vein. We're going to introduce a new phosphomycin anti-infective into peripheral vein. And if we're going to put something into the peripheral vein, it's going to be percutaneous. These are all of the devices or the substances that we could put in them, and it's considered new technology. I'm not going to read all of those because, quite honestly, if I do, I'm going to have to pull out my readers, and even though they're adorable and cute, little cat eye ones, I don't want to have to put them on and take them off. We can do the same thing with the central vein. Same thing. And then, oh, this is new. We're going to do new technology into the mouth and pharynx. So what are we going to do? We have more than one chemical here. Apalutamide, anti-adenoplastic. So we got something to do with cancer. We know the mouth and pharynx. This other one is an eradafitinib. I know I tortured that. Oh, I know you guys are laughing with me, not at me, as we try to pronounce some of these. And quite honestly, when you look at these, how many of you guys pronounce them in your head? You just know it by sight. It's almost like an image or a sight. We don't sit there and pronounce them every time we see it. Things like, and I did a lot of years in pharmacy work, and I got really good at pronouncing some of those, but it's been a while. But I have some favorites like hydrochlorothiazide. I've always loved saying that word. That instead of saying HCTZ, I like saying hydrochlorothiazide. Don't let me get digressed here. So again, we're putting some cancer treatments, new technology. Ooh, all right. Now we've moved into one, measurement of infection. This is great. Oh, I looked into this. I was familiar with this though. So how do we measure infection, right? We check the blood cells. So whole blood nucleic acid base microbial, I can say that word, detection, new technology. So they've got a new procedure to check for infection. This whole blood nucleic acid base microbial, I'll be able to say it later. So now we're getting kind to the end. We're going to start talking about deletions. There wasn't a whole lot of deletions, quite honestly, guys, because it tells us that they're not using this. It wasn't used like they thought, or there was no need for it, or maybe they've explained it in another area. So they deleted bifurcation as a qualifier. So if you go look at med-surg, dilation of right internal mammary artery, bifurcation with drug-eluting intraluminal device open approach. Why? Because we built on it in previously. If you go look, I'm not going to read all those. So bifurcation was taken out. So all of those codes 810 codes were deleted because bifurcation as a qualifier, 7th character, was taken out. Okay, and there's some more. I'm not going to go through every one of those. There's just too many. 90 were taken out of extirpation root operation because bifurcation. Now look, I think root operations, just root operations is the essence of PCS. So go by what's the outcome. An extirpation was taken out. Dilation was that for all those 837 because bifurcation was taken out. Don't ask me why they took it out, though. I can't explain it to you. Extirpation of matter, abdominal artery, 93 codes deleted. Oh, only 15 were done for restriction of abdominal aorta. So for whatever reason, this qualifier is not relevant to track anymore. They also took out external when we're doing alteration of right breast with autologous tissue substitute, external approach. That took out 12 codes. And destruction of right breast external. I think it's because it's a given, right? Of course we're going to do external. What other option is there? Drainage of right breast, external was removed, 9 codes deleted, wham, just like that. 9 codes for excision, 3 codes for extirpation. This is all dealing with the breast. Insertion of radioactive element in right breast. And then 2 codes were for inspection, external approach knocked out. Release right breast, external, because it's a given. So these codes weren't really deleted per se, external was deleted, okay? Repair, replacement, supplement, revision of drainage device. Nope, now we have a really large delete. We got done with the breasts and the external. Now, example of the deleted 128 codes because they took out body part, peripheral artery and central artery. So for transfusion of autologous bone marrow into peripheral artery, and again, because whenever you take out, your 4th character, you make any change to the 4th character, subsequently, the approach, substance, and qualifier is going to also be changed. So again, we've removed peripheral artery and central artery from transfusion of bone marrow. And that is it, guys. This is where you can get the very content that we used to put together this slide deck. This is free to the public. It is on cms.gov. They've got it divided up to where you can look at all of the codes. You can do downloads, and they make it easier. But if you're not familiar with using this, it can be troublesome, but once you get in there and start navigating, you won't have any problems. Or just feel free to come to us anytime. We love doing this. I do. And if you have questions, feel free to go to helpdesk@cco.us. If you need clarifications for anything, you can contact us via the help desk. If you want to have access to this again and again, I mentioned before the CCO Club, we have a fabulous forum. We have subject matter experts that you can network with, and maybe you just have questions that you want answered, and we have SHMEs that can do that. And cco.us/club. Take some time to look there. You can get CEUs, as well as if you join the club and you take courses with us, you get to keep those courses for as long as you're a club member. So in our inpatient course, if you were to take that, you get these updates every year, whether you're still in the course or not, right? Maybe you want to get multi-credentialed, and so you've got an inpatient credential, but maybe you're wanting to get into risk adjustment. You can take that and still have access to all that inpatient content as long as you're a club member. So if you're not familiar with CCO, welcome. Thank you for joining me. I hope you enjoyed our presentation of the updates. We try to make it fun and relevant and applicable to what you're doing, and not just, read what the changes are, because again, you can go to those links and do it yourself. If you have any questions, let us know, and thank you. Don't forget to like and subscribe, and welcome to our LinkedIn people. LinkedIn has started live streaming videos, and we're happy to be able to do that. We live stream on YouTube and Facebook all the time, several times a week. So if you're new in finding us via LinkedIn, feel free to go check out our YouTube and Facebook pages, or stick with us on LinkedIn. and we'll continue to live stream on all 3 of those social media avenues. Thanks, guys. Bye-bye. I'm ending the webinar, Boyd.